HESC 114, Intro to Pharmacology, Chapter 6, Respiratory Drugs. Chapter 6 covers drugs that are used to treat diseases and disorders of the respiratory system. Here is a list of the learning objectives, which are also located at the beginning of your chapter in your textbook. First, we'll talk about conditions and medications used in treating disorders in the upper respiratory system. The upper respiratory system is located in the head and neck, and it includes the sinuses, the nose, and the throat, which is also known as a pharynx. Conditions of the upper respiratory system can include sinus congestion, nasal allergies, and cough. First, we're going to talk about allergies and allergen-specific immunotherapy drugs. One of the things about these drugs is the goal of desensitization to the allergen. So allergy shots and immunotherapy can be used. Allergy shots contain allergens, which is a component. It's actually an antigen that the body responds to that causes an allergic reaction. These allergens are injected subcutaneously once a week, sometimes twice a week, and they're used to desensitize the patient. So the allergen is a substance that triggers the allergic reaction. It could be animal dander, foods, plants, or pollen. Immunotherapy is allergen-specific immunotherapy as an alternative to the allergy shots. Oralair is a sublingual tablet that's made from pollens. The dose is measured as an index of reactivity, and treatment will begin 4 months before the onset of pollen season and continues throughout the season. One of the things when we're talking about something like that, think about here in Louisiana, and especially in the spring, we have a lot of pollen. But it depends on how severe or minor our winter is. And we might have pollen popping up in times when we're not expecting it. So that can be difficult in a place like Louisiana or someplace where the seasons are not well defined. Another type of immunotherapy is for peanut allergies, and that's Palforzia, and it's made from powdered peanut allergen, and it comes in a capsule and is taken orally. It should be broken open and actually mixed in with applesauce, pudding, or even yogurt. Now, a severe reaction that causes a severe allergic response is known as anaphylaxis. Patients who have these severe allergies to things like food or medications or insect bites must keep an EpiPen with them at all times in case of unexpected exposure. Well, not the antibiotic. But we've heard about people that are exposed, they have a peanut allergy and their throat closes up. Use an EpiPen. People who have strawberry allergies or a bee sting allergy. The allergic reaction, again, is known as anaphylaxis, and if the patient passes out and could possibly go into a coma or die, that's known as anaphylactic shock. An EpiPen is one of the brand names of epinephrine autoinjector that's available. The patient could self-inject or someone nearby could inject. The instructions are on the pen and on the package. It's fairly easy to use. Now, I'm just going to note that the example in the book is EpiPen, but there are other brand names. And if you're looking into pharmacy, if a doctor writes for a specific brand, the pharmacy has to dispense that brand. So if he writes for EpiPen, but it's not available and we have another brand name, we have to get the doctor to change the prescription. What happens with this EpiPen or another autoinjector is it's injected into the thigh, and the epinephrine will block the allergic reaction throughout the body. The next thing, call 911. And get the patient to the hospital in case the epinephrine wears off. All right, now other drugs that are used to treat allergies or prevent allergy outbreaks. So there's a number of drugs, including antihistamines, corticosteroids, Decongestants are used for symptoms. They don't actually treat the allergy, but they do treat the congestion, and also mast cell stabilizers. So first are antihistamine drugs. Now, antihistamine drugs are broken into generations. There's the older ones. Those are known as the first generation drugs. These tend to cause drowsiness, and the prototype drug is diphenhydramine, which is known by the brand name of Benadryl. If you've ever taken Benadryl, most people are going to be drowsy. So a first generation antihistamine can cause drowsiness. A second generation antihistamine is the newer generation. These are sometimes referred to as the non-drowsy or non-sedating. All second generation antihistamines are available over the counter. The second generation antihistamine on your drug list is loratadine, as we see it right here, and it's telling you it's an antihistamine. This is by the brand name of Claritin. But if you look at the list in the book, you will also see an isomer, desloratadine. That is Clarinex. So it was the next version of Claritin. So when it comes time for you to learn drug names in your respective disciplines, key in on some of those things that give you clues. Loratadine, desloratadine, they're kind of together. It's got something added on it, the des, so that was the Clarinex, the next version of Claritin. Now, talking about drug stems, second generation antihistamines actually have a drug stem of TADINE. So in chapter 4, when I talked about the GI drugs and I talked about H2 blockers, they're blocking histamine, but they're blocking histamine 2 receptors. Antihistamines block histamine 1 receptors. The one for the GI system has TIDINE, and then the one for allergies is TADINE, A for the allergies. Now be careful, because there are a lot of look-alike, sound-alike, or what we call LASA drugs within this class. To treat the symptoms of cold and allergies, antihistamines are sometimes combined with a decongestant drug. And then your book goes on to talk about Seldane. That is an interesting point. Seldane is an old-time drug that's no longer on the market because it had interactions and it could cause arrhythmia. What they did was they modified it, and they came up with a newer drug called fexofenadine. Now, unfortunately, that doesn't match this drug stem because it's NADINE. So if you want to look at the ADINE for allergies, fexofenadine is what we know by the brand name Allegra, which is part of the word allergy. So they like to make those brand names connect, right? On the TV commercials for Claritin, Claritin Clear, because when you have allergies, you feel kind of foggy sometimes. So again, we have those connections, those associations. Next are corticosteroid drugs. Now, the thing about steroids or corticosteroids is their main role is anti-inflammatory. They are the most potent anti-inflammatory agents. They act by inhibiting the body's immune response to inflammation. Now, here we're talking about allergies, so these are agents that are used for nasal rhinitis, inflammation of the inside of your nose. They're going to help treat or prevent that rhinitis, and these are administered intranasally as a nasal spray. So we see that here on the box. A lot of these are also tied in with recognition. So this drug is mometasone, and here we have the azone, which is one of the many drug stems for a steroid. We could use olone, azone, sonide, solide, but here we have mometasone. Azone, for corticosteroid, the brand name is Nasonex. Nasal, it's a nasal spray. Now, some of the other ones in your book, we have fluticasone, which is Flonase. You want the air to flow through your nasal passages. Budesonide has the brand name of Rhinocort. Rhina means nose. And Cort for the steroid class, the corticosteroid. So Rhinocort. The use of nasal corticosteroids can cause nosebleeds. It kind of dries out the membranes, but it also can have some systemic absorption, which could impair wound healing in the nose and the throat. I'm going a little out of order for the textbook because I want to talk about the ones that are actually impacting allergies before just the symptoms. So the book talks about decongestants next, but I'm flipping it. So mast cell stabilizers, which go ahead and try to say that 10 times fast. It's pretty challenging. So a mast cell is a cell in your body that contains chemicals that when an antigen attaches to the cell releases chemicals to kind of protect the body. That could include histamine, it could include serotonin, it could include leukotrienes, it could include bradykinins. There's a whole bunch of different chemicals. Many of those would cause inflammation, especially your histamine and your leukotriene. We're going to talk about those in this chapter, even though I've already talked about histamine. But these mast cell stabilizers are going to kind of stabilize that cell. They're going to kind of make a protection around that cell so that the chemicals don't come out and then cause an inflammatory response. So they block these cells from being released. They're used preventative because I always think about this as, okay, if you think about a fence around the house, if the house is the mast cell and you've got the dog inside, even if the dog gets out the door, if you have a fence, which would be the mast cell stabilizer, the dog isn't going to get out onto the street and bite somebody. But if you don't have that fence and the dog gets out of the house, you can't take that back. So you have to use these before allergy season. So think about the allergy being the puppy dog trying to get out of the house. The drug mast cell stabilizer, there's one. It's cromolyn, sometimes referred to as cromolyn sodium. I know the image doesn't give the name very clearly. It's kind of blurred there, but it's known as nasal crom. So you got crom from the cromolyn and you got nasal because it's for your nose. Some of the other are for different parts of the body and they have different names. Now, decongestant drugs, these aren't going to treat allergies, but when you have allergies and you've got all that inflammation, you feel very stuffy. You get fluid buildup in the sinuses and your nose can be stuffy and you might feel pain and congestion. Decongestant drugs are actually vasoconstrictors. So if you think of this swollen area with all this fluid as a super saturated sponge, what we want to do is squeeze that sponge out. And by reducing the size of the blood vessels, by constricting them, that's what's happening. That will reduce the size of the blood vessel in the mucous membrane. It allows the swollen membranes to shrink in size, and it alleviates the stuffiness and congestion and allows drainage. Now, because these are vasoconstrictive drugs, oral administered decongestants have to be used with caution in patients with hypertension, glaucoma, or diabetes. The nasal spray is not as much because you don't get as much absorbed, but still might need to use caution, and patients need to make sure they follow the instructions on a nasal spray. They don't want to overuse those. Now, a few more things about decongestants. So here, there's two primary decongestants that are taken orally. One is pseudoephedrine, which goes by the brand name Sudafed, and then we have phenylephrine hydrochloride, and that might be pseudoephedrine PE or Sudafed PE. The PE stands for phenylephrine. It differentiates. And what's important is the drug pseudoephedrine is actually a restricted drug. So somebody could walk into the pharmacy and purchase phenylephrine over the counter. But if they want pseudoephedrine, they have to go to the pharmacy and ask for it. They have to show an ID. It gets run. Now, part of that is due to a law called the CMEA, which stands for Combat Methamphetamine Epidemic Act, and that's of 2005. Sales of pseudoephedrine are restricted to a maximum quantity of 3.6 grams per day, or 9 grams over a 30-day cycle. The reason for that is that pseudoephedrine, along with other ingredients, can be made into meth. So we restrict the sale so they can't get too much of it. Now, Afrin is oxymetazoline, and this is a nasal spray. This is only meant to be used twice a day. Patients don't want to overuse this because if they do, then they could have rebound congestion and think they need more and more and more, and it's just kind of, they become very dependent on it. So again, it's going to cause that shrinkage and open up the airways. Now, we do have benefits from combining antihistamines and decongestants together, and that's because decongestants are actually a stimulant drug, and antihistamines tend to be sedating. So we get that kind of interaction between those two side effects that kind of cancel each other out. Now, sometimes when we do have a combination drug like Claritin with pseudoephedrine, it's known as Claritin D. We put a D, the letter D, for decongestant, telling us there's a second drug added to that, a decongestant drug. So that's Sudafed D or Claritin D. That's the way that we identify, hey, it's loratadine, Claritin, and a decongestant. I've talked about it and I didn't bring the slide up. My bad. I forgot to change my notes. So I've already talked about it, but here's the example. So here we have Clarinex D. So desloratadine is the antihistamine Clarinex, and pseudoephedrine is the decongestant for the D. And this is given 12 hours. Now the other thing, because this is pseudoephedrine, you have to buy it from the pharmacy counter. It's not sold over the counter because of that CMEA Act. Okay, now also talking about the upper respiratory system. Sometimes when you have allergies, you might have a cough, but definitely if you have a cold or just a dry throat, you're going to have a cough. Drugs that we use to treat coughs are called antitussive. Coughing is tussive. So antitussive. Now, drugs used to treat a non-productive dry cough are known as antitussives. They work in the cough center in the brain. And there's two main types of antitussives. We have opioids, non-opioids, and then we have combinations as well. So the non-opioid antitussive drug, the one from your textbook, is benzonatate. Benzonatate is known by the brand name of Tessalon Pearls. Pearls are basically a capsule. It's actually a French word for pill. But it is a capsule, and I have an image here of a Tessalon Pearl. They're little gel caps. Being that I'm from pharmacy, these little buggers like to roll all over our counting tray. It's lots of fun to chase those around. But benzonatate requires a prescription. We see that RX only down here, right? Tessalon Pearl, brand name. We see that brand name symbol. Oh, we got the NDC number. We got the manufacturer. We've got the dose. All the little things we talked about in those first 3 chapters. But coming back to this, it requires a prescription. A couple things about benzonatate. It's dispensed with a warning not to use it with anything else that causes central nervous system depression or CNS depression, like alcohol or pain relievers and things like that, because it would intensify. Also a warning label for the patient to use caution when operating machinery, which means don't drive while you're taking this, and it may cause drowsiness. Now, another non-opioid antitussive drug is dextromethorphan. And dextromethorphan, the brand name is Delsym. This is sold over the counter. Now, in some states, they keep it behind the counter because it has been abused, especially with teenagers. Most antitussive drugs are narcotics or similar to narcotic derivatives. So even though these are considered to be non-opioid or non-narcotic, they're cousins to a narcotic. Now with the opioid antitussive drugs, It's going to probably be a mix with the opioid being codeine. Codeine alone is used for pain, but when we mix it with something else, it can be really good to calm a cough because it causes that CNS depression in the brain. So guaifenesin, which is also known as Robitussin, with codeine is quite often one of the ingredients, or it could be something like Phenergan, promethazine with codeine. That would be an antihistamine with codeine. That's effective for cough. Actually, antihistamines are good antitussives. The thing about the ones with codeine, they're liquid, but they're C5s. And part of the reason that codeine by itself is actually a C2. When we mix it with Tylenol, it's a C3. But when we've got it in the liquid form or a syrup like this, or a solution, you have to drink so much of it to get enough codeine. It's considered to be the least restricted of the controlled substances. And what we're seeing here, we're seeing packaging that could be dispensed in the pharmacy. This is something that you might see in the hospital. So it's actually unit dosed or in a unit of use. So the patient wouldn't get a bottle if they're in the hospital. The pharmacy would send up or put these into the automated dispensing cabinets for the nurse to pull and administer. Now we also have combinations. I know the previous slide had a combination. We had guaifenesin with codeine, but here we have dextromethorphan with guaifenesin and phenylephrine. So in this combination, this is Mucinex. So Mucinex is an expectorant. We'll talk more about that on a slide that's coming up. Dextromethorphan, antitussive, guaifenesin, expectorant, which is also a type of cough medicine, and then phenylephrine for the congestion. So this is for cough and congestion. Robitussin, lots of different Robitussin combinations. We have Robitussin AC, that's Robitussin with codeine. We have Robitussin DM, that's Robitussin with dextromethorphan. There's all sorts of different combinations. It is important to check the label and make sure that the patient's not going to be taking a medicine they don't need with these combination drugs, because there's a number of them. So that was the upper respiratory system. Now moving down into the lower respiratory system. The lower respiratory system includes the larynx, which is your voice box, the trachea, the bronchi, the branches, and then the bronchioles, the smaller branches, the alveoli, and the lungs. So here's a picture of an alveoli. These are kind of, I always think of the respiratory system as like an upside down tree. The trachea is the trunk. That's where the air is flowing through. It branches off into the bronchi, and then it goes into the smaller branches, the bronchioles, and then it goes to where the leaves are, where the air gets exchanged. Those are the alveoli. Now, these are hollow lined, so there's mucous membranes. So there can be mucus that can get in there, and it can shrink the airway, and it can actually dry out and cause plugs, as well as this is all musculature. So in things like asthma, there can actually be spasms in the muscle, which can make it difficult to breathe. So the primary groups of drugs that we use for asthma, we mostly break them into two groups, your bronchodilators and your anti-inflammatory drugs. Now, asthma is a reactive airway disease. It's triggered by allergens. It can also be triggered by stress. But when it's triggered, it causes inflammation, swelling, edema, bronchoconstriction, shortness of breath, and wheezing. So although we have these two main groups, sometimes we put them together as a combination drug and give it kind of a 1-2 punch. So talking about the bronchodilators first, these are drugs used to prevent or treat asthma, bronchospasm, also bronchitis, and COPD. Bronchodilators generally will relax smooth muscle that surrounds those bronchioles and allows them to open up, what's known as dilate, and it allows the air to flow into the lungs. And there's three groups of, or classes of bronchodilators that we use for asthma. inhaled anticholinergic drugs, beta-2 agonist drugs, and PDE enzyme inhibitor bronchodilator drugs. Now that's a mouthful. A lot of times those are referred to as xanthine derivative drugs. So let's first talk about inhaled anticholinergic drugs. So what are they doing? They're against acetylcholine. They block cholinergic receptors. So they block the action of the neurotransmitter acetylcholine, and they work on the smooth muscle around the bronchioles. Acetylcholine causes bronchoconstriction. If we block it, we're going to get those bronchioles to open up. So it allows them to relax and to dilate. The drug in your drug list is tiotropium. The brand name is Spiriva. Now, there's a number of inhaled anticholinergic drugs, and the inhaled anticholinergic drugs have a drug stem. It could be dinium or tropium, but for asthma, most of them are going to be tropium. So here we have tiotropium. It could also be ipratropium, which is Atrovent. Now, bronchodilators drugs, the next one are the beta-2 agonist drugs. So beta receptors, the beta-2 receptors are located in your lungs. They're in the smooth muscle that surrounds the bronchioles, and they mimic the action of epinephrine. So when they get activated, they open the airways. Now, this is known as a sympathetic nervous response. It causes the bronchioles to widen, to dilate. It increases the flow of air into the lungs. These drugs are classified as sympathomimetic bronchodilators, kind of like your own nervous system would act, because they act as like that sympathetic nervous system. Now, there are many different kinds. We have short-acting beta-2 agonists and long-acting beta-2 agonists. Short-acting, those are rescue agents. Those are used in an emergency situation to open the airways. A long-acting won't work. If somebody's in the throes of an asthma attack, they cannot use a long-acting. It will take longer for the medicine to work than the patient may live. So the primary drug in this group is albuterol. This is the prototype. This is a short-acting beta-2 agonist. This is considered to be a rescue inhaler. Maybe you have asthma or you know someone with asthma. They probably have an albuterol inhaler. One of the brand names of albuterol is Ventolin. ProAir is another. Now, this is, like I said, this is an inhaler. You want to review the information on page 150. That little green banner, Focus on Healthcare, and it talks about how to properly use a metered dose inhaler. So on your drug list, albuterol is one of the drugs, and the other is levalbuterol, so it's an isomer, and that's known as Xipenex. Xipenex, and then the HFA, that has to do with the propellant. That means that it is actually a kind of a spray, aerosolized inhaler. We also have Ventolin or albuterol and levalbuterol. They come in vials of liquid that can be put into a nebulizer. Now, your beta-2 agonists do have drug stems. Terol is the most common drug stem, albuterol. And I think when I say that, I hear air for all, to remember, hey, I need to breathe. And Terenol is another of their drug stems. The next bronchodilator is the xanthine derivative, the phosphodiesterase inhibitor, enzyme inhibitor drug. These work to relax smooth muscle around the bronchioles by blocking a specific enzyme known as PDE or phosphodiesterase. They also stimulate the muscles of the diaphragm for you to be able to breathe in deeper. So the drug on your list is theophylline. Theophylline, one of the brand names is Exofillin. I can never say that because in my brain, I'll be honest, when I read theophylline, I can say theophylline, but there's another drug called aminophylline, and when I spell it, I say aminophylline, and that's my way to remember. So sometimes I do change it up. Now, this is an elixir. It starts out elixo. So that tells us it's an elixir. Remember, elixirs have sugar and alcohol with water. And then in the capsule form, it's called Theo24. So theophylline 24. Theo is 24 and he has asthma. He needs to take this to be able to breathe. So the drug stem for this is phylline, theophylline, phylline. I have to back build sometimes to get the correct pronunciation. My brain tells me, but my mouth doesn't follow what my brain is saying. All right, now we're switching to the other side. So open up the airways or stop them from getting constricted in the first place. So an anti-inflammatory is going to stop that inflammation. And the drugs that fall into this group include inhaled corticosteroids, leukotriene receptor blockers, or what we call leukotriene inhibitors, or formation inhibitor drugs, and then also some monoclonal antibody drugs, right? Inflammation's an immune response. Let's stop the immune response by using an immunomodulator. So first, the inhaled corticosteroids. So they work by suppressing the inflammation associated with an immune response. Corticosteroids do not dilate bronchioles. So these are not bronchodilators. These are anti-inflammatory. They can't treat an acute attack because if the inflammation, it's going to take a while for that to calm down. It's not an immediate thing. If they're having an allergy, an asthma attack, they have to have a short-acting bronchodilator like albuterol. Corticosteroids are used to prevent asthma attacks, or we also use them in COPD to help keep the inflammation down. So from your drug list, you have cyclosinide, which is Alvesco, and then we also had fluticasone, which is Flovent. Now, I know on the drug list in your textbook, it says Flovent HFA. That would be this type of inhaler like this Alvesco, an aerosolized. But fluticasone also comes as a powder. This is an inhalation powder. This is called a discus. Discus is actually a form of delivery from GlaxoSmithKline. So every single drug company can make its own kind of machine, and that can change names. So they can be a little bit confusing, but also once you start identifying those, it makes it a little bit easier. It also tells you how the machine operates. Now, again, steroids, they end in sone, sonide, solide, solone. So we see cyclosinide, sonide. We see fluticasone, asone. So there's a number of those. Now, if someone is taking an oral corticosteroid, that would be prednisolone for asthma. Combination drugs can be very impactful. So I kind of am staying with the inhaled stuff right now before I move on to the other drugs that are used that are not necessarily inhalers, but maybe oral or injectable forms for asthma. So we've talked about beta-2 agonists, inhaled anticholinergics, and inhaled corticosteroids. So here I have a beta-2 agonist corticosteroid combination. This drug is a combination of fluticasone, your steroid, and salmeterol, which is your beta-2 agonist and ends in terol. This drug is known as Advair. When you have a combination drug, you're going to see the amount of each of the ingredients. So these are two different ones. This one has 250 milligrams of fluticasone. This one has 500 milligrams of fluticasone. And again, this is the discus. The discus is an all-in-one machine. This is the cover. So right now it's open. And when it opens, we have a mouthpiece. And there's a little lever here. What that's going to do is it gets pushed down and it punctures a little cartridge inside that has the powder in it. And then the patient puts their mouth over the mouthpiece and inhales. And that powder goes down into their lungs. These also have a counter, so it lets them know how many doses are remaining. So I wanted to go over some of the different types of inhalers just so that you kind of had an idea of what they look like. Excuse me. So here we have a what we call a meter dose inhaler, or an MDI. So each one, this one, it's pretty clear here, this one has 80 meter doses. An albuterol inhaler may have 200 meter doses. These have a liquid in them. They have to be shaken. They're put in an L position, placed into the mouth. The patient will exhale, and then as we're pushing down on the canister, the patient's going to deeply inhale so that that will go down into their lungs. Now, meter dose inhalers could be for a beta-2 agonist, a corticosteroid, or an inhaled anticholinergic. This is a Respimat. A Respimat is also an aerosolized, but it actually uses air pressure to release it. This is going to give more of a little spray. Think like you're got a spray paint can and you push it once and you see it come out. It's a burst, where Respimat, when it's released, we push the sides and it just kind of comes out as a small mist. So it's not quite as quick as a regular inhaler, but this is also considered to be a meter dose inhaler, but this is a specific type of delivery device called a Respimat. Then we have dry powder inhalers, or what are known as DPIs. Every different manufacturer makes its own mechanics for its dry powder inhalers. So here is Asthmanex. This is mometasone. It's a steroid. It's used for asthma. So we've got that relation. It's an inhaler. This is an all-in-one, and it's called a twist inhaler. So you twist the bottom and it clicks and releases the dose, and then it does have a cap that goes over it because this is the mouthpiece, and we don't want to leave a mouthpiece exposed in a pocket or a purse or something like that. This is called a handihaler, Spiriva tiotropium, tropium for your inhaled anticholinergic. This one doesn't have any medicine in it. You have to actually put the medicine in. The medicine comes in a capsule. These are not meant to be swallowed. They come in a little foil pouch. We pop out the capsule. This opens up, and you drop the capsule in, and it would be in this little window. And then you push the button, and little spikes puncture the capsule. And then you close it down. Well, you close it down, you puncture it, then you open just the top, and there's a mouthpiece. And then the patient could breathe that in. And then again, here is the image of the discus, which I've already explained. There are other devices, but these are some of the more common devices you may encounter or your patients may have to use while under your care. All right, so corticosteroids and combination drugs are used to be inhaled. For anti-inflammatory drugs that are used systemically, these are not inhaled drugs. The first one being the leukotriene inhibitor. So leukotriene is an inflammatory chemical that lives in those mast cells. So if an antigen, someone's exposed, leukotrienes can be released and it can cause inflammation. Now that can cause the inflammation, cause an asthma attack. So a leukotriene formation inhibitor will block the production of leukotrienes, or it's going to block the leukotriene receptors. So the drug is montelukast from your drug list. There's also zerfelukast. Montelukast is singulair. It's taken once a day, so they put that capital 1 in the brand name. Now the other thing, I have to remember this, for Monty to sing, he has to have air. The drug stem for your leukotriene inhibitor is Leucast. The newer version of drugs used for asthma are immunomodulators, immune response modifiers, monoclonal antibodies. So they inhibit various types of interleukins, which block them from producing an inflammatory response. Now, we have some of these monoclonal antibodies, those MAB drugs, that are specific for asthma, and that is omalizumab, which is called Xolair, and the ones specific for asthma have lizumab as the drug stem. But again, that MAB tells us it's monoclonal antibody. If you learn a little bit more of that drug stem, it may help identify what is it being used for. Now, Xolair is given subcutaneously. Now I'm forgetting the dosing. I want to say it's every 2 weeks, but that's not the concern at this level, right? What's the drug? What's it used for? So this is to stop the inflammation and prevent asthma. Now, moving on to talk about COPD. So COPD stands for chronic obstructive pulmonary disease. And there are two components of COPD, chronic bronchitis and emphysema. Characteristics of chronic bronchitis include inflammation of the bronchi. Bronchitis, itis means inflammation. Inflammation of the bronchi results in severe coughing, shortness of breath, and excess mucus production. You've got inflammation, it's all irritated. Your body's going to make mucus to try to coat it and make it not as irritated, but unfortunately that just makes the situation worse. Now with emphysema, it causes the alveoli, those air exchange sacs, to get overinflated, or what they call hyperinflated. Some of them will rupture. It damages the surface area and the cell wall, so you can't get as much air exchange. And it causes these pockets in those alveoli that traps the air. We can breathe it in, but it's really hard to get it out. Many of the drugs used to treat asthma are also used in treating COPD. Drugs to treat COPD include anticholinergic drugs, beta-2 agonist drugs, bronchodilators, corticosteroid, anti-inflammatory, expectorants, especially with that chronic bronchitis, we've got extra mucus, phosphodiesterase 4 enzyme inhibitor drugs, so a specific type of phosphodiesterase, and then combination drugs. So first, inhaled anticholinergics. Now, some are used only for COPD, some are used only for asthma, some can be used for both. Again, how are we going to identify it's an inhaled anticholinergic? Drug stem. Clidinium or tropium. Tropium is going to be your more common one. Clidinium is a newer one. So this is not on your drug list. It's in your book, but it's not on your list. But I wanted to give it as an example. So this is umaclidinium, and it's Incruse ellipta. So ellipta is the delivery device. So this is a dry powder inhaler, and it's just a different, well, this is the same people that make those discus, but it's a new version of that kind of thing. And a lot of your inhalers are going to have a dose count on it. So be looking for those tropiums or those diniums, clidiniums. I go with the dinium myself. It's more than enough to remember. Some other anticholinergics we talked about previously, tiotropium, Spiriva. It's very commonly used in someone who has, for someone who has COPD. The beta-2 agonist drugs, again, these are going to be bronchodilators, Brovana, which is arformoterol. This is a long-acting beta agonist. This is actually an inhaled solution, and it uses a special delivery device. This is for COPD, not for asthma. So Brovana is for get my words together, arformoterol, Terol. So we've got that Terol, or some have Terenol as the drug stem. So again, relate Terol to the beta-2 agonist, bronchodilator, beta-2, bronchodilator, both start with B. Terol, get that airway open. And then we have corticosteroids. Now, your book gives you oral corticosteroids for COPD because they have chronic inflammation with that chronic bronchitis. So methylprednisolone is Medrol. And then expectorants. So expectorants are kind of like a cough medicine, but these are for a productive cough when there's mucus or sputum. What they do is they reduce that viscosity. If you remember that viscous lidocaine, chapter 2 or 3, I don't remember which one. We want to break that down and make it thinner. It's going to make that mucus less thick, less sticky. If they don't have a productive cough, it may not be much benefit to them. Now, patients with COPD, pneumonia, tuberculosis, people who smoke, who produce excess mucus in their lungs, could benefit from an expectorant drug. If you have chest congestion, you've got a cold, you might use an expectorant. Now, I talked about Robitussin. That can be used for cough, but to break down the viscous part, we would use it orally. And guaifenesin can be cough syrup, or it could be an oral formulation like Mucinex. And if you've seen the TV commercials, right, you got Mr. Mucus. So we want to X out the mucus. So it's going to break that mucus down in their lungs. PDE, or phosphodiesterase 4 enzyme inhibitor drugs. PDE4 creates lung inflammation and infiltration with cytokines and white blood cells. These drugs will inhibit that PDE4. Don't confuse it with the PDE enzyme inhibitor that was talked about previously with the xanthine derivatives. This has a different drug stem. The drug, unfortunately, the image is not real clear, is roflumilast, and it's known as Resp. This is taken orally for COPD, and its drug stem is molast. And then we have combination drugs, just like for asthma. So combination drugs for COPD can contain a combination of an inhaled anticholinergic, a beta-2 agonist, and or a corticosteroid. So the first one I have here is budesonide with formoterol, and this is called Symbicort. They were working together, and there's this corticosteroid. This is a turbohaler, just as a dose image. And then this one has 3 things in it, so it's called Trelegy, like trilogy, right? 3 things, Trelegy. And this contains imdalutamib, no, let me try that again. Imclidinium, I don't know where I was going originally, vilanterol, and fluticasone. So the fluticasone is the steroid. The umclidinium is your inhaled corticosteroid, that dinium, and then vilanterol, Terol, is your beta-2 agonist. When this first came out on the market, I saw the TV commercial, and I have a tendency of keeping a piece of paper next to my seat in the living room, and when I see a new drug or hear about a new drug I don't know, I jot it down so I can go look it up. And I always look for what the generic names are, and I'm like, wow, this was the first one that ever had 3 ingredients. So we've got 2 bronchodilators and a anti-inflammatory all in one place. Where over here, we've got the bronchodilator, the beta-2 agonist, and the steroid together. So they work. One opens it up and one keeps the inflammation away. I know, I'm kind of a dork when it comes to my, drugs are my life. So what can I say? Now, the next part goes on to talk about, quote, COVID, coronavirus. So chances of contracting COVID-19 have different variables based on the closeness of contact you have with an infected person, how long you're in contact with that person, how much ventilation is in the environment, and what are the variant viruses that are present. Symptoms of coronavirus, some of you may have had COVID, include fever, cough, headache, fatigue, and shortness of breath. And then we talk about the treatments. So since the textbook was printed, there have been some advancements and some things updated. But from the textbook, it talks about dexamethasone, which is a corticosteroid and ends in -one. That's given intravenously to help with inflammation in the lungs. Remdesivir, which is Veklury, it's an antiviral drug. We see vir here, that's one of the clues. Now, when the textbook was written, there was only the injectable available. I believe it is also available in an oral formulation now, but the injectable is used for patients who are on a ventilator. We also have antibodies that can be used. They're not using those as often now. What they did in the early stages before we had better medications was they would take antibodies from a person who had tested positive for COVID-19 but who had recovered. So we would use their antibodies and use them in another patient. Now, the monoclonal antibody drugs, bamlanivimab, has been used in the hospitals as well. It ends in VIMAB, so think viral. So antivirals, virs, but Vimab, a viral monoclonal antibody. And like I said, since the textbook was public, Paxlovid, which is a combination drug containing niraparib and ritonavir, has been approved. This drug is given orally. In the fall, every year, we talk about influenza. So antiviral drugs to treat the flu. Most of your antiviral drugs used to treat the flu have the drug stem of mavir or avir. And balozoxavir, which is Xofluza, is a single dose treatment in a tablet. Oops. See, this is what happens when I can't see the little pictures. I actually picked a foreign prescription, but I wanted to show how they come packaged individually. So we're not going to pay attention that I grabbed the wrong picture there. But Xofluza, it's a single dose tablet. It must be administered within 48 hours of the flu symptoms. Tamiflu is oseltamivir, right? And then also Relenza, which is zanimivir. These are both used to treat and prevent the flu after exposure. If somebody has the flu, they need to start treatment within 48 hours, and that goes for any of these. Treatment must begin within 48 hours to get a benefit. Now, with the Tamiflu or the Relenza, they take one dose twice a day. For the Tamiflu 5 times a week, for 5 days, twice a day for 5 days. Now, to prevent exposure, it's going to be a little different. They actually are going to take one dose every day for 10 days. Tamiflu is taken orally, and Relenza is administered via an oral inhalation. Tuberculosis is a condition that's caused by a bacteria known as Mycobacterium tuberculosis. So to treat it, we use anti-tubercular or TB drugs. Because tuberculosis is so difficult to kill, there are resistant strains. We will treat tuberculosis with a cocktail, which is basically a combination of anti-tubercular drugs, often for at least 9 months. So these are very potent drugs. They have a lot of side effects. They can impact the liver. They have a lot of drug interactions. So a lot of times patients are non-compliant. They are non-adherent. They don't take their medicines the way that they're supposed to. Resistant strains of TB can develop when they're non-adherent. And that means even stopping their medicine before they actually get this under control. Patients who refuse or are unable to be compliant may be required to participate in a mandatory program. There's a whole cocktail of drugs. your book lists them, like isoniazid, but on your drug list, I just gave you rifampin, which is Rifidin, taken orally. And then for the multi-drug resistant tuberculosis, they may give an injection of capreomycin, which has the brand name of Capistat. Okay, here we are. We're pretty close to the end here. The last section talking about smoking. So smoking damages the lungs. So we're talking respiratory system. So drugs that help people quit smoking. Drugs for smoking cessation. Nicotine is an addictive substance. It stimulates the brain to increase alertness and performance. It's one of the only chemicals in the body that can stimulate both sides of your nervous system. So it can cause dependency, and it can be really hard to quit. It can cause the bads about smoking. It can cause lung cancer, emphysema, bronchitis, COPD, heart disease. It's also been linked to type 2 diabetes, rheumatoid arthritis, erectile dysfunction, retinal degeneration, people having problems with their eyesight, as well as liver and colorectal cancer. So there's a lot of negatives, and we're not even going into vaping. Okay, that's a whole nother thing. This is just cigarette smoke. Now, nicotine drugs come in many dose forms. They could be chewing gum, lozenges, nasal sprays, inhalers, or transdermal patches. The purpose of a nicotine drug is nicotine replacement. So to replace the nicotine they get from smoking a cigarette, putting it into a different dose form that then could be weaned off. So using something like nicotine transdermal system or a nicotine patch like Nicoderm, transdermal patch, they might stop. This is step 1. So these are 21 milligrams. Both of these are step 1s. They put these on, and then they would, and it tells them if you smoke more than 10 cigarettes a day, you want to start with step 1. But if you smoke 10 or less, you can start at step 2. You're already pretty good. And then for a period of time, you wear the patch, change it every 24 hours. It's important for patients to take the old patches off. We would think that would be a common sense thing, but sometimes it's not. We get patients that come into the emergency room thinking they're having a heart attack. They open their shirt to put on their leads to do an EKG, and they find that they have nicotine patches all over their arms and chest. Transdermal patches, they stop releasing therapeutic levels, but the drug's still there. So if you put enough on, you can get an overdose. Also, keep these away from kids. Never, never, never cut them. Because if you cut them, then you've taken away all of the protective barriers, and any of the nicotine can then come out, and it absorbs very rapidly through the skin. So just proper handling is important. A little few extra things that maybe aren't in the textbook. But anyways, they're going to put the patch on. They're going to take it off, put a new patch on. They're going to do that for about a week, and maybe then they're ready to step down. It may take longer than that. The next drug is not a nicotine replacement. So this is the only nicotine replacement is nicotine. Otherwise, we're going to try to help the brain give up the desire to smoke. So bupropion is an oral formulation. This is actually an antidepressant. It's known as an NRDI. It blocks norepinephrine and dopamine. And it helps stop the craving to smoke. Patients should not smoke while they're taking this drug, either nicotine or this drug. The next drug is Chantix, which is the generic name of varenicline. I love the TV commercials for this, right? They're talking about you can't quit cold turkey, and they have that little turkey guy, and he's always wearing a sweater vest or a jacket or something because, right, he's a cold turkey, and he's trying to quit smoking. I think that's so cute, and it's just to help to remember. But Chantix, varenicline, it's not an antidepressant, and it's not nicotine, but it binds to the nicotine receptors, and it blocks them from being activated by inhaled nicotine. Now, technically, some patients may still smoke, but they actually will lose the pleasure out of it because the receptors are being blocked by the medication. But no smoking with the first two. Okay, that wraps up chapter 6. Here's some more questions for you.